hopefully it doesn't give me too much of a hard time. Sometimes it gives me a hard time when I want to go and cast onto Facebook. Okay. Oh, good. Yeah, we do a we do a GI town hall every year in the
Uh-huh.
spring. We've got some fantastic gastroenterologists in the group. Okay. Oh, I think it's going to let me on the first try this time. It is. That's fantastic. Okay.
You're clearly a lot more technologically advanced. I have no idea how to live cast on a Zoom. So that's something new to me. That's
Yeah.
great that you can do that.
Yeah.
Um,
Well, we are now live here with
Wonderful.
Zongqi Xia. And tell us a little bit about yourself.
Thank you, Amanda. And thank you for the invitation to speak to this group and share my thoughts. So I'll tell you a little bit about who I am. As you said, just so folks know that you didn't just find me randomly on the internet. I'm Zongqi Xia. I'm a neurologist and a neuroimmunologist by subspecialty training. I'm a physician scientist here at the University of Pittsburgh, and my research focus is people with neuroinflammatory disorders, primarily multiple sclerosis. And my research spans from almost the entire spectrum of clinical, translational, and data computational research, centering around neuroinflammatory disorders as well as neurodegeneration that's the result of neuroinflammation. My entry into COVID research stems from my work in using medical informatics to study clinical questions for clinical discovery. And we're part of a consortium, a multinational consortium of researchers that use electronic health record data to study COVID-19 and related clinical questions. But of course, I also study MS and COVID in that context as well. Yeah, so that's a brief background of who I am.
Well, thank you so much. And again, we're glad you're here. We're glad you're doing this very important research on multiple fronts. So let's just dive right into it. We've got some rather lengthy questions, and there may be some that we can't address all of these things. That's okay. And again, all of this is not medical advice by any means. You do need to go see a licensed medical practitioner, someone who's familiar with you, who knows your background, and who can really speak to this best. Because even a licensed medical practitioner should not be giving you advice on the internet. So let's go. We'll just dive straight into it here. Um,
Absolutely.
yeah, this is something I've seen a lot. People are being tested for myasthenia gravis. And again, with long COVID, a lot of these results come back negative, or we're just kind of left wondering. And this is one of these people. The MRI from a year ago was normal, waiting to get results from a sleep study. My physical strength barely exists. I have a bad headache every morning. My memory and thinking skills make me think of dementia. My balance is bad, but not from dizziness. Unexpected sweats, then fatigue. My neurologist thinks I'm anxious and depressed. I took Prozac for 2 weeks, but I'm not comfortable with that. What doctor would look for neurological damage? Different types of testing for the brain, or infection hiding, or antibodies. What are your thoughts on this?
Yeah, that's again, thank you for sharing these questions beforehand, and I read them before, and I find them all really good questions, and they all come from very tough situations.
Yeah.
This particular individual who talked about his experience with things such as headache, balance issues that's not due to dizziness, as well as fatigue prominently, and also um, things such as sweating and so forth. And It's like there's also mood issues. And all this taken together is very common in many of the patients who have recovered from the acute COVID. And the question of what specific tests that need to be done, and is there any infection that's hiding, or is there any antibody? So let me sort of speak to you a little bit about this picture of people who experience this kind of primarily neurological, but some of them are neuropsychiatric conditions. There are a lot of theories, as many of you know, based on studies over the last several years, but also goes back to a larger body of literature focusing on post-infectious syndrome, and some of the best known is from the chronic fatigue syndrome and the ME family. They're not exactly the same, but there's certainly a lot of similarities, as this individual mentioned, when it comes to the neurological and neuropsychiatric domain. There are theories, some of them are supported by evidence, whether it's neuroimaging studies, whether it's neuropathological studies, as well as biomarker studies. For the persistent neurological manifestations after a recovery from the acute COVID. One theory is that there are persistent reservoirs of virus, and that's triggering low-grade inflammation. And these inflammation then lead to the immune system being in an activated state. And that can lead to activation of the immune cells that are resident in the central nervous system, in the brain, and sometimes in the spinal cord. Some of them are called the microglia. And they can lead to damages to the nervous system, to whether the neurons or the cells that make myelins, which then are important for the cells, neuronal cells, to talk to each other in the brain, but also to communicating outside of the central nervous system. So this idea of whether or not there's a persistent reservoir and activated, perhaps low-grade immune, particularly the central nervous system immune cells, is very. There are quite a bit of evidence to support that, and there are also neuropathological studies that show there are. As well as the studies from neuroimaging to show that there are actual damages to parts of the brain. Hippocampus is a part of the brain that are involving memory and consolidation of memory, etc. And there are evidence that there are damage. That's not the only area, but so that's one theory. And the other theory is also along of immune system. In this case, though, it's not specifically the SARS-CoV-2 virus. It is that in the aftermath of the acute infection due to SARS-CoV-2, the immune system is activated in such a way there is this dysregulation is causing other virus that's part of our body. Many of them are kept under check due to our immune system. A good example is a virus that almost all of us have been exposed to, and that's the bar virus, which is not related to SARS-CoV-2 specifically, but in the context of a post-infectious state, which leads to immune dysregulation, there are these other resident virus that could be causing additional immunological changes that can again cause neuronal injuries, if you will. And so those are two related, but not exactly the same, along the line of neuroimmune dysregulation. There are other theories, which is I think very interesting, but not necessarily proven, and that involves so-called microthrombosis, small clots that necessarily detectable through imaging. It's not like there's acute ischemic stroke in which you can look at the blood vessels and
Yeah.
so forth. Those are too small for existing clinical imaging to detect. But this theory regarding small clots that are causing additional triggers of these immune cascades is yet another theory. Uh, along that line, these microclouds, there is also theories about what's called the endothelial damage. Endothelium is the inner lining of the blood vessels, and injuries to the endothelium can lead to what's called fibrosis along the blood vessel wall. So it's along the line of blood clot, but it's not necessarily detectable. So there's a lot of pathological evidence to support that. And so there are lots of theories, and some of them have stronger evidence to support it, and some of them have perhaps lesser evidence. And I think my takeaway is the symptom that people experience in the neurological domain, the neuropsychiatric domain, probably have a multitude of um, uh, reasons. And I suspect it's probably not all going on in the same person, but there's likely differences across individuals. So I want to go back to
Yeah.
this patient, this individual who asked the question, what doctors should be looking for neurologically. I think one of the most important thing people want to talk to their doctor about is to ensure there's no other um, uh, things that we could be missing. So, for example, imaging of the brain is certainly with MRI. That's certainly something worth consider pursuing. It's non-invasive, and it can tell us if there's something else going on. For example, it may tell us whether there is any so-called white matter disease that could manifest. Um, and essentially just to rule out things that can be diagnosed, just to make sure um, there's no nothing is amiss from the conventional point of view.
Yeah, thank you so much. And yeah, and I know just getting to a brain MRI, it takes a few steps. Like you can't just have a spell, go to the ER. They're not going to do a brain MRI in an ER. And as we've talked about in other town halls, an ER is not there for diagnostics. It's there to make sure you're stable. Um, but thank you so much. We'll move on to our second question. I continue to have seizure-like spells since having COVID in August of 2020. They're not as often as they were. I'm on to Pyramid 100 milligrams twice daily, hydroxyzine, uh, and I've had an EEG done in the office and a week-long EEG home study done at home. Both of them were clear of any seizure activity. These spells usually last for 30 seconds to a couple of minutes. I'm usually coherent, and I am able to communicate during them. I shake and tremble just like a full-blown seizure. Usually, I have a warning sensation about a minute before I have one of these spells. Are these very common in the long hauler community? And are there any theories as to why or how the brain is affected by COVID in this manner?
Yeah, that's a good, really good question. Well, first I would say is, seizure could be very serious, and so it's certainly important to establish care with a neurologist, and probably a neurologist who specialize in seizure. There are a lot of nuances to the diagnosis and monitoring, and then treatment of seizure-related disorders. So that's something that needs to be taken very seriously. And whether or not seizure is common in the long hauler or the long COVID community, from my understanding of the literature, it is not common manifestation. But of course, that doesn't mean they cannot be related. It goes back to my first point regarding the last question, and that is when we new symptoms or new neurological symptoms or worsening neurological symptoms, after, in this particular context of a pandemic or post-pandemic period, we don't want to all attribute to just having had a COVID. We want to ensure that things we can diagnose, things we can treat will be addressed appropriately. And so in this particular instance, I just want to emphasize how important it is to ensure that uh, establishing care with kind of neurologists who can help this individual to get the care that he or she needs.
Yeah, and that's it's something we've seen pop up, but again, it's not one of the more common things. And let's move on to our next one. Yeah, this is probably one of the biggest ones.
Yeah.
Any recommendations for managing or even overcoming brain fog, things like word recall, memory issues, executive functioning disorder, and post I'm wording very hard here, post exertional malaise. What kind of strategies or treatments? Uh, like when your fatigue is triggered by physical or even mental or emotional factors, what are some strategies we can use to cope with this? And is there any hope of getting back to 100%?
Yeah. These are such important questions, and we know things such as brain fog, things such as fatigue, or certainly post-exertional fatigue, profoundly impact people's quality of life and the ability to do their not just daily activities, but to do the things they're passionate about. First, I would say brain fog is we don't have an answer. I just want to be honest and say, there's no clear consensus guideline in terms of the best treatment option. So that's not probably the satisfying answer that folks want to hear, but it's something that we have been struggling with from many different communities of patient population. I'll speak for the patient population that I primarily take care of, which is people with neuroinflammatory disorders, predominantly people with multiple sclerosis, which is not the same as long hauler or long COVID community. But in that population, cognitive impairment is quite common. And the strategy that we suggest for those individuals is really a multitude of things. One is to treat the underlying disease. In that case, it's multiple sclerosis. And it's a little bit difficult to translate that into the long hauler COVID community. As the underlying disease, it seems that the patient have recovered, but I know there are again theories, and then I'm haven't looked at all the potential clinical trial that's out there treating, for example, the underlying inflammation, for example, using different. It could be. I'm certainly not recommending any of this, but these are things that people have been exploring, things such as steroid, some of the agents that may target certain cytokines and modulate certain aspects of the immune system. Whether that have direct effect on the brain fog, it's unclear. Another theory, and again, I'll say that as theory, I think of a comparison to folks who may have experienced concussion or post-concussion syndrome. And in those individuals, again, it's completely different in mechanism. However, cognitive impairment is also very common. So there, the focus on things such as cognitive impairment is a lot of rehabilitation, and some of them are occupational rehabilitation, some of them are cognitive rehabilitation. You really need to find the right kind of rehabilitation specialist who understands. I want to come to specifically post-exertional malaise, which is not something that I normally deal with, but I did read about it primarily from the chronic fatigue syndrome and ME community. So there was, and this is something that I did not know about until I read more about this particular literature. In many other fields, the MS field, when people complain about fatigue, a lot of the clinicians recommend exercise as a form of combating fatigue. And I think it's for some conditions that's true. But for the CFS community, it's the opposite, right? We know
Exactly.
that exercise makes the post-exertional fatigue worse.
Yeah.
And I want to go back to that. It's a little bit, the two are related because I want to go back to the brain fog. That's why I brought up the concussion analogy. In the post-concussion period, we do recommend rest, right? We recommend rest in order for the brain to recover to some extent. And rest is not just like sitting there on your couch. It's so the question of physical, mental versus emotional factors contributing to the fatigue, physical fatigue, contributing to potentially the cognitive fatigue, the brain fog, and so forth. And I think there are some analogies to it. I certainly don't have the answer to say how the best way to do. I do think that there are things that could make it worse, right?
Yeah.
Because in some field we say exercise is a good way to combat fatigue, but it doesn't apply
Yeah.
here. And cognitive stimulation to some extent. I think it also has a temporal aspect. Is
Yeah.
in the immediate acute phase or the early post-acute phase and potentially the later phase. So I think there's a lot of research that needs to be done. And we need to have the right kind of investigators. We need to have the right kind of biomarkers for people to say, is it really a thing that we can measure people go through these phases. There's also, I think, brought up this very important point about will you get back to 100%? I always like to maintain a sense of optimism, not a false optimism, but an optimism to say that there's a lot of smart people trying to study how to make things better for people who are experiencing brain fog and other long hauler symptoms. And research takes time, but the fact that there are so much attention and so much to,
Yeah.
I'm optimistic that we'll learn a lot that will translate into the clinical arena to help help folks who are experiencing these persistent symptoms. So I hope, and of course there's also a lot of individual differences, and I hope people will maintain a sense of cautious optimism even as they cope with the day-to-day struggle.
I agree. Yeah, there is a lot of attention on it, and there because of the funding that's going into it right now and the pressure globally. Yeah, fingers crossed. I'm optimistic too. Let's go on to it's sort of another sub question here. Let's talk about impacted taste and smell. Why is it
Mhm.
happening? This person has been at about 40% for about 10 months, and they also have a dissipating appetite sensation, and they no longer know when they're hungry. And this is something we've actually addressed in prior GI town halls. But is there a neurological, is there a neurological thing word into this?
Yeah. This is one of the most peculiar thing, even during the acute phase, right? I mean,
Right.
and certainly during the earlier waves of the viral variant, anosmia or ageusia, the loss of smell and taste were so prominent, and it's striking. Patients will tell me about there's a striking experience with the loss of smell and taste. I think there are some evidence to suggest that the olfactory bulb, which is sort of more, if you will, the primitive part of the central nervous system, but it is part of the central nervous system. There are, from pathological studies, there are injuries or, if you will, damages to the olfactory system. And so whether that is from direct virus, which is unclear. These studies have not detected the virus specifically in the olfactory or the central nervous system in general. I mentioned in my very first comment, there is this idea of a low-grade reservoir of the virus, but that's not the same to say that there's evidence of virus that's
Yeah.
easily detectable. So that's more of a hypothetical a theory. But in the case of olfactory, there's olfactory bulb, which is part of the central nervous system. There's clearly damages in some individuals for whom the autopsy has been done. And so that can explain some of the loss of smell taste. But there's actually a really interesting study, a couple of studies that I read, which is the damage to the olfactory bulb. So if you can think about the nerves from the olfactory bulb goes into other parts of the brain, which at the higher level, if you will. But once you have damage to one part of the lung neuron or the cells of the nervous system, you can cause damages to the other part of this lung cell. So that is, if there are damage to the olfactory bulb, whether it's due to initial virus that's no longer detectable or due to immune activation that somehow damage the olfactory system, you can lead to more long-term damage to the olfactory cortex, if you will, the part of the higher part of the brain that that would be actually longer lasting. Olfactory bulb is the one part of the central nervous system that has quite a bit of a regenerative potential, but as opposed to the other part of the central nervous system, which is, as you know, it's much harder, if at all, to be able to regenerate. I want to say something else about the loss of appetite, which is
Yeah.
probably more, it's not so much of a neurological. I guess it's everything is neurological to some
Yeah.
extent. If you cannot smell or taste, for the reason, whatever the reason may be, if you cannot smell and taste is such an integral part of what drives the I guess the rituals of eating, the rituals of which then feeds into the satiety circuitry. So if you cannot smell or taste, the food just doesn't taste the way that will trigger the hunger. So there's a lot to do with why people who experience loss of smell and taste also lose appetite. So that's I think it's a lot more complicated than what I just said, but
Yeah.
that's the, I would say, the general gist.
Okay, thank you. Um, let's skip down here. For 2 years, I've
Mhm.
experienced areas of my body, usually on my legs or feet, warmth areas, but it's happened on my arms as well, that make me feel like they have a heating pad on them, but are normal or cool to the touch. It's never the entire extremity, just localized to small areas. I've had ultrasounds to look for clots, and none were present. Outside factors do not seem to affect or influence them. They've tried putting ice packs on them to cool them, and they don't really seem to do anything.
Yeah, that's really interesting. It's this phenomenon. It almost sound like there is a hypersensitivity, but to a very in the words of this particular individual, a small area, localized to a small
Yeah.
areas, right? And the answer is I don't know what that is, but I would say not being able to examine the patient, but getting a proper examination will be helpful to localize neuroanatomically, whether that goes into localized to parts of potentially the spinal cord, which can lead to abnormal sensations that people experience, or is a part of the so-called somatosensory part of the brain. I think this is worthwhile seeing a neurologist who can do a proper exam, or it could be non-neurological, right?
Yeah.
It could be injuries that directly due to part of that part of the skin, the dermis.
Hmm.
I give you an example. I should have mentioned earlier about fatigue, which is something that's common in folks experiencing the long hauler syndrome. In addition to all the things that I mentioned in the nervous system, central nervous system, which is what I'm most interested
Yeah.
in, what I study. But there's also evidence that the virus injure the muscles as well as the neuromuscular junction, which then lead to makes it harder for people to do things, right? And so that's part of the uh, uh, it's entirely that whether the in this particular instance, it could be to the result of injuries to the skin, but also to the nerve ending that is uh, uh, providing the sensation, if you will, to that part of the skin. So I think it's very intriguing, but it really requires a bit of an investigation wise. I'm, from the point of view of the current clinical care, I still goes back to I think,
Yeah.
my comment about the first patient. Do a proper, see the proper specialist and do the proper exam just to make sure there's nothing that can be diagnosed will be missed if that makes any sense. So
Yeah.
you rule out those things can be diagnosed, can be managed, then we can attribute to things that may be still in the research space because as I said, people haven't figured out all the answers, but we also want to make sure people don't miss things that can be easily diagnosed.
Yeah. No pressure or anything. So, thank
Just
you.
just tell NIH to
Right.
you know right.
I'll get rid of it. Let's see. We've got two more questions here. It seems like, and this is something I actually hear a lot. It seems like my fibromyalgia has gotten much worse after having COVID. I'm having more flares that last longer. I've also had some pressure points that ache all the time, even without being touched, but now they hurt all the time. Also, those on my right side hurt more than my left side. Is this my new normal, or does it get better with time?
Yeah, that's a good question. I confess I don't know as much about fibromyalgia as I probably should, but I do know that people who have had COVID and certainly in entering into the long haul phase, it's not just appearance of new symptoms, which is what we see, but also worsening of symptoms of condition that they may have had pre-COVID, if you will. And fibromyalgia clearly is one of those. Again, that may have to do with one of the many different pathogenesis mechanism that I alluded to earlier. So in this particular individual, the worsening fibromyalgia, whether or not is it due to having had a COVID, is certainly a strong possibility. I think pain is some of them are joint pain, some of them are neuropathic pain. Those are just like the brain fog, just like the fatigue, are common manifestations following acute phase of the COVID in folks who recover from the acute COVID. I don't have a good answer. I would say, talk to the doctor who follow you for your fibromyalgia. Tell them about things getting worse. Are there things that they can do to further alleviate the fibromyalgia symptom is what I would suggest in that particular case. I do hope that just like my point about the person who asked about the brain fog and the fatigue, I do hope that individuals will get better over time. There is a I do think there is a strong, almost like a circular physical symptoms, and then people can have normal reactions to these physical symptoms, but they do have this sort of feed forward loop. So I think having some cautious optimism will help perhaps break down some of that feed forward loop. That is, you have a physical ailment, and then the anxiety and stress, which is rightfully so, as a result of is not feeding further forward into making the symptom worse. But I profess I know very little about fibromyalgia, so
Yeah.
so I.
Yeah, it's one of those many diagnoses that we receive, not because we had a test that it was positive for something. It's a rule out diagnosis. Thank you, rheumatology, for for helping in that regard. And I've received this one. This is the last one. We had a question regarding I'm speaking great here today. Normal pressure hydrocephalus and shunting, and whether that's something, if that will subside over time as well.
Yeah, that's these are all great questions. I'm not quite sure about at least from what I have read, I've not seen too many reports of association between either acute COVID or certainly the post-acute long hauler with normal pressure hydrocephalus.
Yeah.
And now, of course, one of the treatment for normal pressure hydrocephalus, if not amenable to medication, is so-called ventricular peritoneal shunting. That's what presumably what this individual is referring to. And, the good thing about normal pressure hydrocephalus is it should be treatable. And again, my advice is to see see a good neurologist, and potentially in the case of shunting is a good neurosurgeon that may be partnering with the neurologist.
So do you have any final thoughts for us regarding neurology issues in long COVID, and what your trajectory is like? Any thoughts? Throw them out there.
Sort of free thoughts. I say, one of the things that that I'm really keen on is there's so much we need to understand through doing research, and through research by working closely with the patient community directly. And this is why I think clinical translational research is, particularly in this context, is so important, because it's the patient who tell us the question that we need to pursue. And then obviously we need to bring the research findings in this particular instance even faster than usual. The translation to the clinical space through clinical guidance is often very slow. But given the magnitude of the issues that we're facing, this community, I think we need to do more. And it's not just the money NIH spends on research; it's how they spend. And obviously, in just reading about, there was articles written about this, but we also need to engage different kinds of researchers, many different clinical domains and many different expertise. And for all of you out there who are experiencing this, is um, do what you can to be part of the research efforts, because no research can take place without your support, your participation, your advocacy, and uh, you telling the story that we can drive questions, the research to answer the right questions. Um, and yeah, those are my sort of very generic comment, but I think about research, how
Yeah.
important research is, because if we don't do research, it will be just status quo. We will
Yeah.
never you'll be just one clinician sitting with one patient saying that, well, we don't really know the answer, right? And one of the things that motivates my career is that I listen to the patient, but it's what drives our research questions, and the hope with the hope that what we find can be translated into the patient community. In this case, we're talking about long hauler, but as well as in many other patient population.
Yeah.
It's really I think the same in that regard.
Yeah, it's a pretty extraordinary time to be sure. So thank you for all of your work. Thank you for being here for us today. We really appreciate it. And let's keep in touch and best of luck to you. I know you've got current research. I've been sharing that in the discussion group, so I'll make sure to go down and bump that so that we can get some more responses and let's do research, people.
Thank you so much, Amanda. It's nice meeting you as
It's good to meet
well.
you too. Yeah, thank you. I'm gonna go ahead and hit end here.